Undervalued, or how inequitable reimbursement in gynecologic surgery harms patients. Gynecologic surgeons are among the most highly trained specialists in medicine, and yet they are the lowest paid surgeons in the field as compared to other surgical subspecialties such as general surgery, ENT, urology, plastic surgery, or orthopedics. In addition, the gap between reimbursement for gynecologic surgery and other subspecialties is widening. In this video, we'll explore how decreased reimbursements and the gender pay gap ultimately leads to poor access to care for our patients. And this isn't just an issue of fairness, it's a public health crisis. The reimbursement gap disincentivizes talent, limits operating room access, delays care, leads to fewer surgical resources such as staff and equipment, and ultimately harms patients. General OBGYN residency includes limited surgical training. OBGYN training involves 4 years of residency, and each year only contains a few months of surgical exposure, meaning most OBGYNs experience 18 months maximum of surgical training. This training path leads to most OBGYNs becoming low-volume surgeons. In contrast, subspecialist gynecologic surgeons complete 2 to 4 additional years of fellowship. They have low complication rates comparable to or better than their surgical peers, yet they are paid significantly less. So how did we get here? The Relative Value Unit, or RVU, was first created in 1989 by Congress through the Omnibus Budget Reconciliation Act in order to standardize physician reimbursement. The Center for Medicare and Medicaid Services, or CMS, assigns a relative value unit for every procedure, which determines how much each procedure gets reimbursed. But gynecologic surgery was underrepresented and undervalued from the start. In practice, a surgeon performs a procedure, then the healthcare provider sends a bill for the medical procedure to CMS. CMS then reimburses the healthcare provider based on the set number of RVUs allocated to each procedure. And 90% of private insurers involve the same payment system as CMS. In the 1990s, the passing of the Social Security Act gave the Department of Health and Human Services, or HHS, the power to appoint the American Medical Association to make recommendations on medical billing. The system that emerged was the RUC, or the Relative Value Scale Update Committee. The value of every procedure is determined by the RUC, which consists of 32 voting members. These voting members are physicians who are appointed with the intention of representing the entire medical profession. Of these 32 members, OBGYN gets just 1 vote. The total number of RVUs that is allocated to all medical procedures is finite with an annual cap of $20 million. Obstetrics and gynecology are allocated a subset of these RVUs. This budget has not changed since 1992. To maintain budget neutrality, obstetrics and gynecology compete within the same pot, a false choice no other surgical specialty is forced to make. In addition, in order to increase the number of RVUs allocated to obstetrics and gynecology, this would mean taking away from other specialties. But here's the kicker. The RUC uses surveys to estimate how much time and effort each surgery takes. These surveys are sent out by ACOG to a small percentage of their general OBGYN membership. So the RUC's RVU recommendations are based on flawed and inaccurate data. Of the members that received this survey, the median response rate is 2.2%, with an average response rate of 52 OBGYNs, of which there are no separation of gynecologic surgeons from general OBGYNs. What this ultimately means is that most of the people responding to these surveys have not done complex pelvic surgery and either don't report it at all or they underestimate the time, the skill, the risk. Many OBGYNs perform just 1 to 5 hysterectomies per year, and studies showed this low volume correlates to higher complication rates. And then that flawed data becomes our national pricing system. Double discrimination in gynecologic surgery. Double discrimination refers to the fact that this lack of parity comes from both discrimination against patients and their providers. Procedures completed on female patients receive less reimbursement as compared to the same procedures performed on male patients. Equivalent surgeries for men, like urologic procedures, are reimbursed at rates up to 149% of their female equivalents. At the same time, most gynecologic surgeons are women, and female physicians earn less than their male counterparts. In an analysis of physician compensation from 2014 to 2019, it was found that men on average make over $2 million more than women over the course of a 40-year career, and women surgeons are paid only 70% of what male surgeons earn. Studies show that the more women there are in a medical specialty, the less they make. Gynecologic surgery is the only female-dominated surgical subspecialty, and compared to surgical subspecialties dominated by men, make considerably less than their surgical peers. Fixing this system starts with recognition and action. That includes representing gynecologic surgery on the RUC, pressuring CMS and Health and Human Services for reform, revamping the survey distribution and response system, exposing the gender pay gap, and considering legal strategies. Gynecologic surgery isn't just women's work, it's life-saving work, and it's time it was valued as such.